Awesome. What's up, everyone? We got Ahmad here, who's been super helpful across previous global health hacks, judging, and just being one of the most helpful people I know supporting early founders and startups. You want to give a quick introduction on yourself before we talk through what you've got on your desk?
Yeah, thanks for the intro. Yeah, I come from a medtech background. I've led strategy and engineering for multiple medtech companies. I do advise for a few, and I'm so huge avid fan of hackathons overall. I love the output that comes out and really the ability to unlock and kind of like see the future. So yeah, that's my background.
Awesome. So, goal in this 10-minute call, we're going to do a quick introduction on remote sensing and what's on his desk to help you all build. Then we'll go into some different ideas and we'll end with a few questions. So, I'll let you take it away.
Yeah. So I've been in the world of remote sensing for the last 10 plus years, and you see such a huge fluctuation, different types of devices in the market today. You know, the word ECG, the word heart rate seem like Apple Watch type of output. Yeah, everyone's familiar. It's almost consumer level. The question now comes down to what is clinical grade, right? What is diagnostic grade? How do I make decisions using devices around me? You know, whether that's a camera, whether that's a sensor, whether that's just a reading on a piece of paper, right? The question is clinical decision making as a result of environmental data collection, I would say overall. So I wouldn't say it's even have to be sensor based. It could be someone calling me and telling me, "Hey, Ahmed is sick." You know, I hear congestion and I hear, I don't know, he seems tired, short of breath. Cool. That's actually medical journaling. Now we can do that digitally, but it's not necessarily something you have to do with technology. So you know, what I've spent my last X number of years doing has been building telehealth remote patient monitoring platforms, all down from sensor grade all the way through to the algorithm side as well. And so today I can showcase a few examples of that, you know, with VivaLink, one kind of key kind of solution I built on, but I've also built on others. And I'd love for you guys to kind of play with these things and figure out how you can solve problems using either sensors or using nothing, but really thinking of what is the core problem you're trying to solve. So I can take a moment here. One thing I want to highlight is really to be problem specific. I think it's so easy to get tech engraved and you know we get really enamored by the idea of using technology to solve your problems. Most of the time, you'll really figure out that if you ask a doctor what they want to see, they won't actually know that. You know, they won't really know what that looks like. They'll say, "I just want more data." But what do you want to do with it? A good key example right now in industry is continuous blood pressure monitoring. It's kind of seen as the holy grail. If you were to ask someone what's the holy grail, they'll say, "Oh yeah, if you can capture ECG, SpO2, and continuous blood pressure, that really tells me almost everything I want to know about a patient." No one's really been able to do it, right? It's really seems to be something difficult to do via sensors for multiple reasons. But let's kind of go back a second and figure out why do I need to know that. And so, if you talk to most doctors, if you go do your interviews, talk to clinicians, talk to people on the ground, understand the need for that, it comes down to, oh, actually, I don't need continuous blood pressure. I just need to know a patient will take a recording 3 times a day, and that'll give me a nice trend. And so you may ask, okay, well, why don't I just have a patient take it 3 times a day? And you're like, well, compliance is low, right? It's hard to get someone to do something repeatedly and consistently. And so maybe sometimes the answer is not continuous data recording, but maybe the answer is how do I improve compliance? How do I make it really easy for someone to come out and take a recording? How do I make it habitual, the behavioral thing? All these things could be other factors that could be solved outside of technology, but that's just one good example. So as you start this hack, think about what is the problem I'm trying to solve here. Is it lack of resources? Is it accessibility? Is it resource constraint? Is it clinical diagnostic yield? Is it just like, I don't know, is it like preventative care? Is it chronic care? Whatever that is. So I think that's the key thing to start with. And then I would kind of jump in here to kind of some of the tools I'm going to provide you all to play with. And then happy to recommend others as well. But
Before
one
we
of the
jump
kind
into
of the
the
fun,
tools, could you maybe
yeah.
give like a quick mental model for a way of filtering things that do make sense and things that don't make sense? So the framing of like, hey, get to the end result, work backwards for the almost the minimum amount of data needed for the maximum decision action taken. Because if you can't guarantee the action or decision, no amount of data is going to fill that gap. But I'm sure
Yeah.
you probably have one example where you're like, this is one I really like. You also have an example of like, here's what not to do. Here's the one example of too much just doesn't quite add up, just so people can really solidify
Yeah.
that as they think through problems.
Yeah, exactly. So I think there's a global context and there's a domestic context.
Hmm.
One kind of key context to think about, and this is how you evaluate. I think this is how I go about evaluating medical technology in general, right? The first one's going to be, what's the key problem? What's the unmet need I'm filling here, right? You should be able to answer that yourself. The next one's going to be, does the solution I'm providing actually solve that problem, right? Like, is what I'm trying to think through here in this hack, is that really solving the initial problem that we defined? Next question, again, this is a kind of an interesting question, and it will change depending on the demographic you're talking to, but who's paying for it, right? Like, how is this getting into someone's hands? This solution, great, I can cure cancer, but it's going to cost $1 billion a person. Okay, who's paying for that? So that's kind of another general idea. The next one is interesting, and I would love to kind of see how the Nairobi team versus SF team think about this, but it is a regulatory landscape, right? If I'm doing something that's meaningful, it usually means there's some type of regulation on it, right? It means that there's something that is constraining me from just telling someone, "Hey, you have a heart attack." It's like, do I really have one? Is it true? So, this is not consumer technology. It's meant to be something clinical grade. And so in Nairobi, maybe think about that. What is the government regulation around that? Are there regulations? Maybe there aren't, which is great. I mean, there's a market for it. In the US, what is that? Elsewhere, what is that? Next, I think that which is the interesting one, which is what are the current products in the market, right? You aren't unlikely to be the first person to come up with something. Why, why are you, what's your unfair advantage? Why are you solving it better? And so I actually love this for Nairobi more than I have for the SF, because in Nairobi, I believe that there are so many ways to solve problems in a different way. I do tend to believe that people who are less or more resource constrained are more creative. And we've seen this in other places in the world where they've taken something that we take for such is granted, and have been able to scale it out to huge populations of people to create meaningful change. So that's something I think is cool. So a good example of how to use this technology, and how a bad example. Good example is really, like, for example, I mentioned this to Michael. One thing that we've worked with a partner on has been, if people know, in pilgrimage, for example, you'll have millions of people go to Mecca and they're doing pilgrimage. And Mecca, as you know, is in Saudi Arabia. It is a desert. It's going to be hot. You have millions of people crowded on one another. They're just all, in crowds and walking, and you have different ranges of health. And so a key problem was, hey, we just want to be able to prevent death that's unnecessary, right? And so how do you do that? And so they thought of a cool, interesting solution using our platform to monitor patients while they're in pilgrimage, to know who's sick, who's overheating, who is having a heart condition, and able to kind of track that. So that was a cool solution, which is, we have tons of people. We want to be able to monitor the highest risk patients, and we have ways to deploy to them. So we have kind of ambulances sitting aside who can know right away, oh, patient X, I know exactly where he is because I have his geographic information, because of the mobile app. I know where they are exactly in this crowd. We can then have someone go look at them. I think a bad example has been, I've seen, where people have just taken the tons of technology. They're taking a full telehealth kit, meaning like an entire RPM kit, SpO2, blood pressure, ECG, and then taking it to a rural environment, forgetting that internet was scarce. And so you just have a bunch of data just sitting on a phone, not being able to get to any patient. And so they thought that, hey, we're going to bring this rural care to this place. They never thought through, oh well, there's no data in this space. What do we do? Is there weird places to use Wi-Fi? And so cool solution has been, just to tell you guys it, they changed it to become a peer-to-peer network. They said, you know what, we can set it. We don't have internet bandwidth, we don't have much control over our internet accessibility, but we do have peer-to-peer networks that can be formed, and that's their solution. So really creative ways to go about both problems.
I appreciate the filtering in the beginning. We actually just had a doctor in Nairobi say, "Here's my idea. I want to figure out what the open evidence is for Nairobi." The same exact checklist, which is just it's best practices for when identifying the right problem and saying, "Does it make sense to solve this? What are the blockers for why it hasn't been solved before?" And I think that for the good example, the one thing I want to highlight is when you have remote patient monitoring and the data is mobile, the response also has to be just as like agile, mobile, and adaptable. So for that example you shared, being able to have different medical teams on site in ambulances and EMTs, they can literally like drive and run around to solve the problem. Where even in some urban areas, that's not common. So the more you distribute the data, is it on the patient to get themselves to the clinic to act? Or so I really like that example because there's a level of mobility for that response or that action where either the clinical or the medical team is responsible for being able to deliver that, or you have to figure out in what ways can you bridge the patient to that action, because not all contexts will be able to serve each patient depending on what they
Yeah.
need.
Yeah, I'll then add maybe one other kind of caveat, one example. So one kind of cool thing I'm going to present to you all is really, one big application for telehealth has been kind of hotspot home. This idea is, can I remotely monitor patients with acute, maybe chronic conditions from home? And can I institutionalize that? Can I basically have an entire health system rely on this as a actionable and meaningful care model? And it's worked. And so the funny part is people assume this started, in the 2020s, basically post-COVID, as a way to free health systems of high burden, or basically to free up some beds. And actually, the funny thing is, Hospital at Home was created was initially launched in Australia in the 1980s, pre-technology, pre-telehealth technology. They had a different model. They said, hey, our goal is actually just to remove as many people who don't need to be in the hospital from the hospital. Let's find a way to do that. And so they didn't use technology to do it. They actually did it pretty much just on an operational scale. And ironically enough, hospital at home is struggling to scale in America due to constraints of technology because it's hard to scale technology. And again, that question, who pays for it, that becomes difficult. They scaled this in Australia by saying, hey, we're going to go as lean as possible, but we want to make it something that's scalable as possible. So yes, we won't have all the bells and whistles, but we can touch the lives of maybe 100 to 200,000 people and monitor them appropriately. And they found ways to do that. So I do encourage teams to think through that. Maybe the Y Combinator model makes sense. Can I do it manually before building something? Can I do it? Can I just send a questionnaire out instead of having to send out text notifications? And whatever it may be. So I think that's the question I think that I find most meaningful and interesting is, is building it always necessary, or is building or buying it always necessary? Can you go with something that's, a little
And even
leaner?
from a design perspective too, it's like human in the loop from a data perspective is usually when is a human reviewing a workflow and automation and agent, where a lot of times agentic right now means more human effort in the loop. So even for like self-driving cars for Waymos, you have a whole team teleoperating that last 5 to 10% to make sure there are no incidents. And so in this case too, for human in the loop, it's like, hey, figure out from a community health perspective, a medical perspective, a clinical perspective, where the human sits in the loop that actually benefits just to get the job done, which in Australia, the objective function is prevent unnecessary hospital admits. Such a clear KPI. And from there, you can break down what's the highest probability and easiest to triage and from a preventative measure. So super helpful
Okay.
there. Is there anything you want to jump in on the sensor side?
Yeah, I want to showcase some of the kind of specs of the stuff that you will have. I think there's kind of two ways. Again, I think Michael will share this more through during the hack, but we do have some hardware here for you to play with. Let me share my screen. So I'm providing, you'll have, one example of a device that's been pretty powerful in the market today has been this patch here. And so this patch here, you'll have, a few of these to play with. Again, not necessarily just nice show and tell, but a nice example of how remote patient monitoring can work, right? Again, you can also see the downsides here. But let me kind of talk through one of these sensors. This is an ECG sensor. There's a single lead device meant to collect your electrocardiogram data. It's basically collecting at 128 hertz sampling rate. It does collect both heart rate and heart rate variability. It may have, also collects things like respiratory rate. It has an accelerometer on there, so it does collect things like activity, posture, step count, which is pretty useful. The final one being skin temperature. So it's not core body temp, it's skin temperature. Just so I want to clearly distinguish between those two things. But it's still a helpful metric in trending overall skin temp, right? If you're in a really high environment, I can say, yeah, this patient isn't 98.7, but he started at 100, now he's at 110. That's not very good. That's tend to re-increase. Maybe they're in an unsafe environment, for example. Kind of core, and this is kind of a core enabler and maybe a core reason not to use it, right? It is a BLE device, so all data needs to be transmitted to a phone or gateway. So all the data it's collecting is being transmitted to a mobile app, which you'll have access to. Beyond that, there's actually onboard cache. So in the case that you do have customers or patients who don't have access to a phone, they may have to come into a clinic and basically get this patch applied to them and then sent home. It doesn't mean the data doesn't go anywhere. The data sits on the patch itself. It has about 30 days of onboard cache sitting there, which is great for these kind of rural environment applications. It is a rechargeable device. So I would say this looks, it's kind of like an AirPod. You essentially are going to apply an adhesive to the back, which you'll have access to. And then when you peel that adhesive, you can wipe it down, put it back in the case, and it can be used over and over and over. So it is cost effective in that way. It's also something I would say interesting in the global market. The U.S. market is highly about disposable things, like a one-time use thing. That may be okay here because you know, highly wasteful, unfortunately, and we're okay with it. Another place in the world that's not something okay. And so is both an economical solution as well as a highly green solution. So that's something great. It is going to be something IPX friendly, meaning it's something that is shower proof, waterproof. It doesn't mean you can submerge it in like a pool or hot water or anything. So don't do that. And it's meant to be an adult product, so it's tested on on adults. So that's kind of like one tool you'll have to your disposal. I want to give you an example of kind of other kind of workflows people have used, and maybe I encourage you to build your own if you'd like. But really, there's plenty and plenty of devices in the market. You'll find like a dime a dozen. You'll find hundreds of devices in the market that are collecting end user data. Remote patient monitoring data from this patch I mentioned is a ECG patch, a multivital patch. There are also things in the market that are like SpO2 devices, blood pressure devices, CGM devices, actigraphy divided devices, weight scales, and there's a ton more, right? And so be mindful of whatever disease state you're looking to solve. Be mindful that you are building something that is pulling the right data. Don't force feed something and say, oh yeah, I'm gonna just get I need ECG and blood pressure and SpO2 and CGM just because it sounds so cool. Like, are you actually measuring those things? Are those necessary for your clinical diagnosis? So think about that. Again, simpler is better. And so you'll have this app, and then you'll have access to the data in a bucket, in an S3 bucket. So we can show you how to do that. I did want to show you basically the next thing being here. Really, kind of, there's so many different types of ways to collect endpoint data, right? Biometrics data. So be aware of that. And yeah, and I would say have fun. The last part is, I do encourage you to kind of simulate your own data if you can. And I think Michael can showcase that to you maybe during, I don't know if you want to do it now or you want to do
We'll
it
do a
during
quick thing
the
now.
hack.
So my favorite thing
Yeah.
last hack, we had one hardware vendor was like, hey, here's our documentation. And there was a person all the way in the back pulling up their docs, downloading their docs, threw it into an LM system. So I was like, man, great bias towards action. For anyone listening to this, don't wait until Saturday or the hack to start building. Listen to this, pull it up. So all I did, you show us the ECG data. If I'm like, man, I'm not one of the teams with the data, or I don't even want to touch data, I don't want to touch the hardware, I just want to touch the data. All I did was Control A, Control Z, a public web page. You could get documentation better than this. And I was like, hey, for this, please make a synthetic data set for severe hypertension. Control V, we're using O4 mini, so it's light reasoning. And boom, I've got a basic synthetic severe data set. We've got 24-hour of patient monitoring, 15 minutes over the past day. It highlights what it's added in. So I could even talk to this, say, hey, change these parameters, make it more extreme, make it less extreme. We just talked about continuous monitoring might not make sense. Make it 3 times a day over a week. And so I just wanted to show this for people where I don't think it's obvious for most people where not only can you do full patient profile simulations where you don't have to just do one test over the hack, you could do hundreds if you are ambitious, right? So you can actually design the simulations based off the patient profile, the anomalies you're trying to detect, how you're trying to detect it. You can generate a bunch of different data sets. And also, you don't need the hardware. So if there's hardware we don't have in this hack, go find the best in the world provider and the cost and simulate it. So this is,
Yeah.
again, obvious for people already doing it, might not be obvious for people who are there. And I just want to get your take. How do you use this personally? Like, are we really just being hackers and hacking it, or is there actually? No, I see you
No,
shaking your head.
yeah.
You're like, hey,
Yeah.
actually, I use this personally. Help us understand from that perspective.
Yeah, exactly. So, I mean, as you all know, right, it is, every human's different. So you want to be as all encompassing as possible in building a platform, an alerting system, whatever it is. And so, as we talked about earlier, right, the more data I have, the more liability I have, right? I get more of this actionable insight. Now, what's actionable? That's the question. And so, one thing I've used simulated data for has been alerting mechanisms, right? When do we send out alerts to clinicians? Because a huge other aspect is alert fatigue, right? People are just so tired of notifications all day. So we want to make sure that we have high sensitivity, high specificity, and we're not wasting people's time. And so I've used that exact same tool that Michael just literally pulled up on generating hundreds of data sets to simulate different conditions for various parameters. Say, hey, let me kind of simulate a situation where this patient may have hypertension, may have this, may have that, and is in an environment that's very high humidity and and whatever, and is this age. And what's also cool is that they're also public data sets. So if you're like, you know what, I don't know if GPT is enough for this. I need to go pull a data set, tell GPT to learn from it, and then simulate from that and add noise or add whatever it is. That's something else. And so the one thing I would want to say again is, sensors are garbage in and garbage out. So the reality is, if you have poor user, I guess, experience or poor user, I guess I don't know, usability. I was saying not user usability overall all that you just have done is essentially just build like a black box where I said, oh yeah, I made everyone use my product. And at the end of the day, due to maybe poor education, poor onboarding, none of what you did actually mattered. And so maybe that's where you go back and say, well, how do I make sure I almost like dummy proof this product all the way through to make it like almost impossible to use incorrectly? And that's where I see, honestly, 80% of error in healthcare comes from user error. So we should be aware of that and find ways to solve that with AI, with workflows, whatever that is. So
Such a
yeah, really
good
cool
place to end on.
tools.
There's so much you just mentioned that you could double click on and do a whole project series of projects on. One just like hot take as we leave. What's the moonshot in remote monitoring? What's something that you're like, hey, in the next 10 years, it's a little bit implausible right now, but it's possible to get there. Help us increase our ambition. For people thinking about remote monitoring for the first time, what's the North Star here? Is it fully distributed hospitals and institutions go away? Is it every patient has the right amount of data and it's a total preventative system? Help us understand the moonshot, and we'll use that to let people get creative for the hack.
Yeah, I think that the key thing here, I think, is going to be on the preventative side. Preventive health doesn't work in a lot of health systems because health systems today are usually incentivized by downstream surgeries, by all these things. That's how they make money. So, there are very few existing infrastructures that have found value in preventative care, unfortunately. However, you have the opportunity here really with RPM solutions. If I can monitor your data from day one, right, and I essentially can act as your all around PCP, right, your primary care physician, and I can say, hey, I'm going to know all about you for the year. I can see where you're trending and where you're not trending and where you're going. That one visit isn't good enough, right? And so I may need to use more. And so the question is, how do you scale preventive care and how do you make it profitable and actionable? And that's really, I think, the North Star is, can someone do that? And I think RPM and telehealth solutions could be the enabler of that. And maybe not. Maybe say, no, it's actually not true. We don't even need any of that. So I'd love to kind of see where people take that.
That's awesome. And I appreciate you ending on that because I think that was one of the biggest opportunities we saw from the first series of hacks last year, being able to figure out what the business model is, what the economic incentive is. We're not looking for VC level pitches where everything is fleshed out. But we're also not looking for naive projects on the desktop where it's like, oh, first time I've heard we could do RPM. Let's just see what we can build. That's a good starting point, but you better not end the hack there. You've also got to figure out who pays for it and where. So awesome. Thanks so much for making the time. Can't wait to see what people build, and we'll call it here.
Yeah, yeah, cool. Yeah, reach out, guys.